Good morning, and we are into lecture number 2, interactions of X-ray radiation with matter. So this is just a review, kilovoltage peak, highest energy level photons in the X-ray beam from the control panel. Controls quality of photons in the X-ray beam. Mass is a product of the current and the amount of time in seconds that the X-ray tube is activated. How much radiation the quantity is directed towards a patient. Since these factors are chosen by the radiographer is usually responsible for the dose the patient received during an image procedure. So what happens? X radiation is produced, human tissue is struck by X radiation. Then what happens? X-rays pass through without incidence, X-rays interact with body tissues, absorption of energy. X-ray photons can interact with atoms of the patient's body and transfers energy to the tissue. This transference of electromagnetic energy to the atoms of the material is called absorption. So as I mentioned in class, these 4 X-ray photons come in. Absorption happens at the head, happens at the shoulder. Transmission happens when it goes right to the image receptor here. Attenuation. In an X-ray enters a material, in our case the human tissue, they may interact with the atoms of the biological material in the patient, pass through without interaction. If energy is transferred from the X-ray to atoms of the patient biological material, we deem this as absorption. The more radiation received by the patient, the greater the possibility of biological damage in the patient. The amount of energy per unit mass is referred to as absorbed dose. Again, the same image here with absorption and transmission. Absorption. Energy is neither lost or destroyed. Transference of electromagnetic energy to the atoms of the material. Absorbed dose is the amount of energy absorbed per unit of mass, and that could be in any object or soft tissue. Production of primary radiation. When high-speed electrons hit the target, the anode, made of metal tungsten or tungsten rhenium. So the electrons shoot across, hit the tungsten target, and then it goes out of the glass envelope. The glass window and layers of aluminum are deemed permanent inherent filtration. So those are the parts of the tube that were not added. The radiation that emerges from the tube is referred to as primary radiation. Filtration of the beam. Inherent and added filtration of X-ray unit. Inherent filtration is the glass window, 0.5 millimeters of aluminum, and yes, they will ask you these kind of things on the registry. Added filtration, aluminum within collimator, 2 millimeters of aluminum. Total filtration, 2 millimeters of aluminum. As I mentioned before, know the difference between aluminum and lead. Most of aluminum is pretty lightweight. It does allow for X-ray photons to pass through, so it's a great material to use. It's cheap and it's lightweight. Is the beam heterogeneous or homogeneous? We already mentioned that it's going to be a heterogeneous beam. That means that all of the photons, the beams that come from the tube, will be of varying energies. Due to the part of fluctuating voltage across tube during exposure. Energy of the primary photons. As we have learned, all of the photons do not have the same energy when leaving the tube. The energy is expressed in kilovolts. In a regular diagnostic X-ray unit, the energy of the average photon is about 1/3 the energy of the most energetic photon. What does this mean? So if you select 90 kVp on the control panel, the average energy of the beam is going to be about 30. Primary exit radiation attenuation. This figure shows the primary beam right up here. That's anything that comes out of the tube. It gets attenuated, means it does not hit the image receptor. It actually it gets absorbed into the tissue or bounces away from the image receptor here. These two, the primary beam comes out. Direct transmission goes right to the image receptor here. In this case, the difference between beam number 1 and beam number 2 is there's small angle scatter at this one. So again, attenuation is where it's either scattered away or it's absorbed. When an X-ray beam passes through the patient, it goes through a process called attenuation. Attenuation is a reduction in the number of primary photons in the X-ray beam that reach the predefined destination through absorption and scatter. Some of the X-ray photons pass through the patient to the image receptor without interacting. This is called direct transmission. A lot of you spoke about this in your discussions, and basically, like when it goes right through the lungs. The lungs are just hollow organs. It goes right through to the image receptor, giving us our black densities on the picture. It gives us the grays colors in our soft tissue and gives us the white image of our bones. Attenuation is the reduction in the number of primary photons in the X-ray beam through absorption and scatter. Absorption, total loss of radiation energy. Scatter, change in direction of travel with potential loss of radiation energy. X-ray beam passes through patient and does not interact with tissue. Direct transmission of beam through tissue. Exit photons strike image receptor. This equals optimum image quality. So there's no fog, there's no scatter. It's just either direct transmission or it goes away to the patient or it just gets absorbed. Not all X-rays are transmitted through direct transmission. The optimal X-ray image is formed when only direct transmission X-ray photons reach the image receptor. This does not happen. In clinical situations, scattered photons reach the IR and degrade image quality, sharpness of the image. This is termed indirect transmission when X-ray photons interact and lose energy, but still hit the image receptor. So in the instance of a small angle scatter. In practice, radiographic grids and the air gap technique are utilized to reduce the amount of indirect transmitted X-ray photons. So we will increase the patient's dose because we have to increase our technique, but it does reduce the indirectly transmitted X-ray photons. Primary beam exits radiographic tube, absorption of photon, photoelectric effect. Just remember with something with this, that also has to do with fluorescent yield. So definitely understand what fluorescent yield is. Direct transmission, no interaction with tissues. Compton is indirect transmission, that's scatter. Coherent indirect transmission, scatter. So all of these have to do with diagnostic radiography, photoelectric effect, Compton, and coherent. So what's the problem? Scatter. Small angle scatter means the beam changes path slightly but strikes image receptor, as showed right here. Large angle scatter means the beam changes path in a large manner and misses the IR, as shown here in beam number 3. That all contributes to radiographic fog if it hits the image receptor. Contributing factors and methods to reduce scatter production: thickness of patient part, use of abdominal compression bands. We really don't see this too often, but it is a way to reduce scatter. Prone position for abdomen because it flattens the abdomen out. Size of the field, use tightest collimation possible. And we'll see that when we show you the sternum and the L-spine in future more slides. KVP, use lowest KVP possible for structured images. Attenuation diagram. Number 1 is considered an exit image forming photon, would be termed direct transmission due to the no interaction between the photon and the body. Number 2 is also considered an exit photon. However, it shows the path being bent small angle scatter due to the interaction between the photon and the tissue of the body. Small angle scatter decreases the appearance of an image by blurring the sharp outlines of structures. Undesirable addition exposure can be called radiographic fog. Number 3 is termed as a scatter photon. The photon interacts with the tissue in the body, and the change in direction caused by the interaction will deviate it from reaching the image receptor. This photon has been attenuated. Number 4 is termed an absorbed photon. It has transferred all of its energy to the patient and has been eliminated. A photon ceases to exist when it gives up all its energy. This photon has also been attenuated. Radiographic fog, what can we do? If we reduce the amount of tissue irradiated, we can decrease the amount of fog produced. In this radiograph, we can do this by collimation. So as you can see here, all of the photons are hitting here, 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 just basically everywhere in the abdomen. But here, when we collimate, you can see the detail is a lot greater. You can see the invertebral foramen. We can see the disc space more clearly. when we collimate all of the photons to this one area right here. Not only that, but the small bowel is very sensitive to radiation. All of your epithelial tissues are here, so it absorbs a lot of the radiation of photons. So this is what we want to reduce, is the amount that actually hits the organs when the physician only ordered the spine. Another example, here we can actually see all of these details that you can't see in this other image of the sternum. You can barely see the outline. Yes, there's a sternum here, but we don't really see if there's a fracture. We can definitely see the body more clearly. We can see the xiphoid tip, which we don't see in this other image. Differential absorption. Differential absorption occurs because of Compton scattering, photoelectric effect, and the X-rays that are transmitted through the patient. The X-ray image is the produce from the difference of these interactions. So here we have photoelectric absorption. Here we have Compton scatter, and that's actually what hits the technologist or other people in the room. These are the ones that are transmitted, and again, the ones that come from the tube are the primary beam. Differential absorption examples. This image shown is a great example of differential absorption. Bone absorbs more X-ray photons because of its high density appearance. It appears white. Also think of its atomic number. It's got an atomic number of about 13. Soft tissue, not being as dense, appears gray. It has an atomic number of about 7. Air is very similar. Air being the least dense appears black. It has an atomic number of about 7. Overall blackening of the radiograph is called radiographic density. In digital radiography, this term is called image receptor exposure. So again, as I mentioned in class, this is your S number, your DI number, your EI numbers, and that way we can check if an image is overexposed or underexposed. So here, range of exposures on analog film. So this is what I used about 20 years ago. This is film. If you don't put in the correct technique, the image can be underexposed, optimal, overexposed, extremely overexposed. So you had to be really good on your technique back then. Now with digital image receptors, it's something called exposure latitude. So it doesn't matter if you shoot it too high, if you shoot it too low. Pretty much every image gives you something optimal. So underexposed looks decent, optimal looks decent, overexposed still looks good, and extremely overexposed is somewhat diagnosable. Why is this too important to pay attention to image receptor exposure? This is where dose creep comes in. So dose creep is where a technologist is basically just shooting a high technique or doesn't care about positioning because we can just reshoot the image. And this is just causes more exposure for the patient. 5 types of interactions between X-rays and matter. Again, just a review from Mr. Dawes' class 2 semesters ago. These types are coherent scattering, photoelectric absorption, Compton scattering, pair production, and photodisintegration. So these these three here are found in diagnostic radiography, but the two most important ones are the photoelectric absorption and Compton scattering. Photoelectric absorption in your text will say either between 20 or 23 up to 120 or up to as great as 150 for kV. Importance of various interactions of X radiation with matter. Again, coherent scattering, not important in energy range. That's pretty much low energy. Compton is important in diagnostic radiography, photoelectric, diagnostic radiology. Pair production is therapeutic radiology, nuclear medicine, PET scans. Photodisintegration is also therapeutic radiology. Coherent scattering, also called classical scattering, elastic scattering, unmodified scattering, Thomson scattering. So the registry or RadTech bootcamp may call it one of these other terms, but it's basically coherent scattering. Very low energy photons usually occurs at less than 10 keV. So incident photon comes in and just gets scattered. It doesn't have any interaction with the inner shells or outer shells or nucleus. The scattered photon travels in different directions. It is a scattered photon that travels forward. No energy was transferred and no atom was ionized. Found in diagnostic imaging, but no significance. Most important one is the photoelectric absorption. We call it photoelectric effect. Interaction between X-ray photon and inner shell electrons. The X-ray photon surrenders all energy to the inner shell electron. The electron is then ejected from its inner shell, creating a vacancy. The ejected orbital electron is called a photoelectron. X-ray photon yield is the likelihood that an atom will emit an X-ray when an X-ray photon excites it. It is also the ratio of the number of X-rays emitted to the number of X-rays that hit the material. Again, it all has to do with the atomic number, the energy, and which shell it hits. The K shell, the L shell, the M shell. The photon electron is usually absorbed in the human body, thus increasing patient dose and contributes to biological damage of tissue. I've seen this question many times um, on the registries and in RadTech Bootcamp. The vacancy in the inner shell will be caused a cascade effect. With each outer shell electron dropping into an inner shell, a release of energy is caused. Release energy is in the form of a characteristic photon or characteristic X-ray. Another thing that it could also create is called an Auger electron, which is not a characteristic photon or characteristic X-ray, it's just an electron. But when you have free-floating electrons that go through the body, if it combines with something else, it could form something that could harm. Again, X-ray photon comes in, hits an inner shell, a photoelectron comes out, then the cascading effect, more photons are ejected or electrons. The probability of a photoelectric interaction depends on the energy of the incident X-ray and the atomic number of the atoms in the tissue. So if it hits air, if it hits the soft tissue, if it hits the bone, it's all going to have a different type of interaction. Photoelectric interactions contribute to patient dose and are more likely to occur the relatively low kVp is used. So that's why in order to say patient dose, we say high kVp, low mass. The atomic number of the absorber is high, produces short scale contrast. So if it hits bone, it's going to produce a short scale contrast since the atomic number is about 13. Higher mass density and body part thickness. So the thicker the part, the more dense the part is, it's going to create more absorption. Most important mode of interaction, without it, there would be no different absorption and no demonstration of various structures. Responsible for radiographic contrast, all or none interaction. Lower kVp, more photoelectric, more contrast. Consequence of lower kVp, more patient absorbed dose. To reduce patient exposure, use appropriate kVp levels. Again, type of tissue, atomic number. I would know the atomic number of bone. I would know the atomic number of soft tissue and air. Photoelectric absorption, mass density, and thickness. As we can see, same amount of photons. And depending on the part thickness, again, here's the atomic number of soft tissue. Here's the atomic number of bone. Less transmission to the image receptor. Here, soft tissue, same atomic number for soft tissue and on either side, but the part is thicker. So the more thicker the item, the less transmission to the image receptor. And I say item because it doesn't always have to be a person. It could be an object. In diagnostic radiology, greater the difference in photoelectric absorption, the greater the contrast in the image. As absorption increases, so does the potential for biological damage. Radiographers should choose the best technical factors that permit adequate contrast while delivering the smallest dose to patients. If tissue or structures being imaged are similar to surrounding areas, what can we do? So then basically we have to introduce something with a higher atomic number, which is going to be your contrast right here. All of the structures in the abdomen are very similar. The liver is similar to the kidneys, similar to the muscles, small bowel, large bowel. We can't really see anything until we introduce the contrast or unless the part is calcified. Again, we have contrast in the bladder. Compton scatter, also called incoherent scattering, inelastic scattering, modified scattering, responsible for most scattered radiation produced during procedures, most responsible for dose to the tech. So recoil electron comes in, hits the outer shell, scattered photon. Interactions occur when an incoming X-ray photon interacts with an outer shell electron. In this interaction, the X-ray photon surrenders some energy to dislodge the electron from the outer shell. The X-ray photon loses energy and changes direction, called a Compton scattered photon. Just a diagram of how the scatter comes in, hits the patient, comes towards the radiographer. Luckily, they're standing behind the secondary barriers. What does this image tell you about the Compton scattering? So it's basically dangerous for the radiographer or anybody else in the room. That's why we try to limit the amount of family members that want to come in and observe. Compton scatter photons contribute to radiographic fog and degrades image quality. When utilized in fluoroscopy, the Compton scatter photons may expose personnel who are in the room. Increase X-ray kVp to reduce scatter. Pair production happens in radiation therapy. Pair production does not occur unless energy of the X-ray photon is at least 1.02 million electron volts. What does this mean to us? This happens in PET scanning. X-ray photons interact with nucleus of an atom and its energy is converted. When this happens, the energy from the incident photon produces two new particles, a negatron, which is an ordinary electron, and a positron, a positively charged electron. The negatron will recombine with any atom that it needs another electron. So it comes in, hits the nucleus, creates a negatron. However, the positron will interact with an electron and they will annihilate each other. From the annihilation, 2.511 million electron volts photons moving in opposite directions are formed. So again, the 1.002 splits into the 0.511. High energy photon collides and is absorbed by the nucleus of the atom. This occurs at above 10 million electron volts, found in radiation therapy. Does not occur in diagnostic radiography, only in therapy and PET scanning. Incident photon comes in, hits the nucleus, and the nuclear fragment pops out. All right, and then these are just some questions that you should be aware of. What controls quality of the beam? What controls the quantity of the beam? What factors can be increased to reduce radiation exposure to the patient? What happens to image quality when you increase this factor? What structure will undergo photoelectric absorption, bone or soft tissue, and why? What are the two most common interactions of X-ray photons and matter? Compton scatter and photoelectric absorption. As the kVp increases, which type of interaction is most likely to occur? Compton scatter. What type of interaction involves the whole atom, the atom itself? Coherent scattering. What type of interaction involves an inner shell electron? Photoelectric absorption. What type of interaction occurs within the therapy range? Pair production and photodisintegration. What type of interactions involve the nucleus of the atom? Again, pair production and photodisintegration.